Next important talk by Dr. Thomas Cherian. He is in retina practice for 3 decades, and he will talk to you about the communication skills. That is the most important thing, because our patients will not get 6 by 6 like unaided 6 by 6 and 6 like our cataract counterparts who give absolute normal vision. So we have to tell and communicate with the patient regarding their prognosis. Over to you, Thomas, for your words of wisdom.
Thank you, Mahesh, for squeezing in my social studies talk in between these scientific lectures. I've been asked to talk on 3 pearls in communicating skills with a retina patient. Pearl number 1, give realistic expectations. Your patients come to you, the treatment could be either a laser or an injection or a vitreoretinal surgery. In any of these cases, or just observation in fact, or in either of these, you should give only a realistic expectation. Don't say everything will be all right with one injection, or you are going to read small print, and you in fact have to tell the patient that despite all these treatment, you are not going to read the small print. We are trying to make you independent. So that should be a realistic expectation in many cases. Another issue which I recently faced was one patient came to me. He had gone to some other center. He had a diabetic macular edema, and the consulting doctor there told him that he might need 50 to 60 injections. What I would like to say is, don't scare a patient like that. You are talking about diabetic macular edema. Tell the patient that you need an injection. At the same time, don't scare him with these large numbers of 50 or 60. We have to tell them that many patients require multiple injections. It could be 2, 3, 4 or 5. But we have a few patients who have gone for 25 or 30 or even more injections. That's it. And don't scare him. Likewise, when you go for a surgery, tell him what exactly you expect from this and not to give unrealistic expectations. Pearl number 2. Take the patient along with you and make him or her a part of your decision making. What I mean with this, a patient might come to you. You know fully well that this patient requires a vitreoretinal surgery, or he requires an injection, or whatever investigations to be done. But after explaining all this very lucidly to the patient, give him or her the freedom to take the treatment or to walk away from you. What I usually practice, I don't force a patient into treatment on the same day, except in one condition where a patient with a postoperative endophthalmitis is referred to you as an emergency. There, I more or less try to get the patient into treatment on the same day itself. And also to a certain extent for subfoveal choroidal neovascular membranes, AMD, where the time factor is very important. Otherwise, never force a patient into taking the treatment. He should have the freedom to walk away from you, take the treatment or not. And make him or her a part of the decision making. Make him understand what the outcomes of the treatment are going to be, what it would be if left without treatment. He might have so many questions, whether alternative systems of medicine can help, whether a glass can help and all that. Explain very patiently, but the patient is the final judge on what treatment he is going to take. Pearl number 3, do not hide your complications or poor results. All of us are faced with situations when not all our patients do well, not all our patients come out with outcomes which we expect at the beginning of treatment. Sometimes we fail in our surgeries. Sometimes, despite our injections, repeated injections, the patient's condition might worsen. We have to discuss with the patient. First of all, we have to tell the patient that the surgery has not given the expected results. We have to discuss the patient as to ways and means to rectify it, whether he needs a resurgery, whether he needs a change of drug, if you are giving an intravitreal injection, all that. And if you feel that it doesn't stay within your hands, never hesitate to refer it to a colleague whom you believe can do a better job than you. Or at the same time, the patient also will have a confidence when he takes an opinion from another colleague. So that is referral whenever needed. So these are the three pearls which I'd like to put across when you are communicating with a patient when you are doing a vitreoretinal practice. Thank you.
Thank you, Dr. Thomas. Any comments?
When you talk to the patient, what happens is they tend to imbibe mostly the positive aspects of the surgery, and sometimes the negative ones don't go in that frequently. So do you encourage having family members also with you when you're discussing the problems and the complications that are possible and the outcomes of surgery? Would that be a help for the patient to make a decision?
Certainly, I would like to have the family members, not just when you discuss about surgery. Every patient, when I examine, I get the patient's family member also along with him or her when I examine the patient, because might not mean anything, but when you propose a surgery, the patient will have to just nudge at the family members, the spouse or the son or the daughter, okay? And that nod is more important. That gives you the go-ahead or the green signal to go with the surgery. So that is very important, and the family member is also taken on board while making the decision.
Thomas, usually in larger centers, the medical counseling is a little different from the economic or financial counseling. But when you are a single person practitioner and things like that, how do you explain about finances to the patient? What is your advice to that?
I work in a larger center as well as I'm a single practitioner. So I've gone through both this. When you are in a larger center, of course, most of the things are taken care of. But there also I try to go to that medical counseling from my part itself, rather than leave it to the counselor. When you are a single practitioner, let me give an example of how you counsel for an injection. You have a lot of injections now available. When I'm talking about an innovator drug versus a biosimilar, I would like to tell the patient that there are two drugs here available for you. One is the original drug, which is imported, and the second is an Indian model, which is more or less the same. So you can take either. Now, when you want to go to the higher drug, you can say it costs little more, it costs this much. But then these are the specific advantages of this drug over what you have taken in the first 1 or 2 injections. So I would suggest that you take this if it financially suits you, and maybe you get a free injection after that. So likewise, I go for counseling for injections when I'm doing it from my side. Similarly, for surgery also, certain things you want to do, you want to use oil, you want to use gas, tell the patient openly what is the advantage of oil, what is the advantage of gas, and what are the disadvantages of both. And the cost also, there will be a little bit of variation in these. That's all.
Thank you, Thomas. Ultimately, if you see your appointment list and see the follow-up dropout, then you will know how good you are at communication. Suppose you have 50 appointments and 45 are coming every OPD, that means you have a very good communication skill. Suppose half of the patients are dropping out, your communication has some problem. This is one final test you